key facts given by WHO on the August 2020, and of course, improvement of quality of life of patients who are facing challenges associated with life-threatening illnesses, whether physical, psychological, socio spiritual, and of course, the quality of life of caregivers improves as well. 5.56.8 million people, including 25.7 million people last year alone, are are in need of palliative care, and about 14% of those who need palliative care are currently receiving it. So, in the palliative care, you are looking at the physical, psychological, social, spiritual, the key players of palliative care. And of course, you have the medical aspect, the counselors, the social workers, the lawyers, and of course, the religion aspect, churches, Islam, Hindus, and all that. Necessarily restrictive regulations for morphine and other anesthesia-controlled palliative care medicines deny access to adequate palliative care. So there are drugs people might sneak in. One of them being morphine, as far as cancer is concerned. Morphine, what it does, it reduces the pain of cancer patients, especially those who don't have access to medical services. Um, they tend to use morphine in even larger doses, and of course, adequate national policies, programs, and of course, resources and training palliative care among healthcare professions is urgently needed in order to improve access, so that at least they don't only concentrate um, on patient alone, on medication alone. They also concentrate on the medical, on the spiritual and the social aspect, the community, the family, and of course they get to look at the way forward as far as improving life is concerned of cancer patients, of course, having to fight for their rights as well. And of course, palliative care will continue to grow as a result of aging of populations and the rising burden of community diseases and some communicable diseases. Early um, delivery of palliative care reduces unnecessary hospital admissions and the use of health services. And of course, palliative care involves a range of quality services, or palliative care involves a range of services of professions that all have equal important roles to play. Just like I said, the medication aspect, you need the physicians, the nurses, support workers, the social workers, the paramedics, pharmacists, physiotherapists, and volunteers, counselors, caregivers, and of course, they need to be taken care of physically. For those who might not be able to move a lot, they need to be supported, maybe washed, maybe fed. That is work of the volunteers, pharmacists, to know what medication they need to eat or what they don't need to eat. Physiotherapists for exercises, and of course, I'll add the nutritionist to know what to eat or not what to eat. The paramedics, in case of any emergency, support workers from the counselors to the religious leaders to um, to even the people who believe in witchcraft and what have you. And of course, there's the nurses, there's the physician nursing who need to be taken care of. Need to be whose medication needs to be managed, and of course the physician, the oncologist, drugs to treat. That is basically their work. And of course, that is a small diagram. have palliative care, end of life care, death, the improvement, the minimal disease, direct active disease, directed treatment, diagnosis, screening, and of course there's a curative aspect care, palliative care, and yeah, you're going to get these notes. Of course, palliative care involves genuine commitment to the whole person, including managing the patient's physical, psychological, spiritual distress, and thereby seeking preserves patient's quality of life. You have to improve quality of life for the patients, and of course, palliative care provide should and needs to be provided, not instead of traditional medicine or quality care, but in collaboration with all appropriate active cancer treatment from the moment of diagnosis, even before diagnosis, and even through the remainder of patient's disease trajectory. And of course, in social care support, the palliative care is concerned with the psychological counseling and psychological support. There's the social workers, there's the lawyers, those we can't also violate their rights. There's the emotional, the counselors, the caregivers again, and the spiritual well-being, the religious aspect in which this person is in, the well-being and of the patient and the family members, and the care and support, encouraging patients, family members to express their feelings about the disease at their present circumstances, while providing ways to improve psychological and emotional well-being, and provide this appropriate psychosocial care and support. Patients will need to be considered within the context of the family and community. So palliative care will get to help patients realize that is the second chance towards life, and therefore give support to family members to express their feelings and their thoughts about the disease. If my loved one dies, what next for me in this life? Where, what, where will, what will I do from here on out moving forward? And how will life be? And of course, support will be required, and patients need to be considered within the context. Patients need to know what do they really want moving forward, and of course, what will society perceive as far as concerned. And then there's the psychosocial needs of palliative care patients, and of course, the effects of life-threatening or life-limiting illnesses are likely to affect all the aspects of cancer of the patient's social and emotional life. They will get to disrupt a lot. Uh, Life went this way, tomorrow it went another way. So psychosocial needs are unique to each patient and change over time. While assessing these psychosocial needs, it's helpful to keep in mind that the progression and the impact of the disease, the patient's age and maturity, and other factors such as personality and, of course, cognitive ability, as well as the quality of patient's personal relationships. The friends will die off. Not everybody will be there as far as cancer is concerned, and it's about improving the quality of life of this person moving forward, so that at least they're not fighting this battle alone called cancer. Of course, physical symptoms related physical related symptoms. Physical symptoms such as pain and fatigue contribute to anxiety, depression, and insomnia. And of course, physical, psychological, social, spiritual symptoms are interrelated. Anxiety, depression, fatigue, pain, and are the four most common symptoms patients with cancer experience, and they can continue and contribute to insomnia. You, you, you cannot diagnose a major depression if someone is not in pain, and if you get the pain, you are under control. The next day, the patient is usually depressed. And of course, successful management of one symptoms may contribute to the severity of other symptoms. And we ideally continuously minimize each of these symptoms of the patient's medical course. Of course, suffering from total pain. Um, there's the pain and the separation from loved ones, separation from your work, separation from school, what you loved doing, how you lived life. If I lived a healthy life, what would have happened? And all that will be questions um, patients will ask themselves, and patients who are critically ill suffer from total pain, and some of them um, will include actual separation from loved ones, fears, and concerns about the effects of the illness, deteriorating physical and cognitive abilities, anxiety about possible death. They'll be anxious. What happens if I die? The fears of their illnesses, actual separation from loved ones, that they won't do what they loved doing, the frequent hospitalizations, stigma, what will the society perceive about the illness that this person has cancer, the shame that maybe this person was an active member, but now being there, they'll see the shame, and the people will show that sympathy instead of that empathy. They will how will they really take it? And of course, poor communication with family members due to denial or mutual protection. Family might decide they might cut off their member due to the lack of protection. They will not be really there for them. And of course, shame about changes, appearance, or this frequent loss of organ, the effect of chemotherapy, and going for and body changes, fear of rejection among friends and peers, um, that they might not go around with their patient anymore because of how they look, and of course, low self-esteem, and they will focus on their own image rather than embracing themselves and fighting and accepting themselves for who they are. So there's also depression, PT, is the post-traumatic stress and adjustment disorders. They have to adjust to life change, that I'll be going to hospital from this time to this time for treatment, for chemotherapy, and what have you, for surgery, frequent for checkups every now and then, and so and so. And of course, there are social problems that may be experienced by cancer patients in palliative care, so that and these common problems are mainly patients who will spend long hours in hospital to have frequent hospital visits, and they'll disrupt a lot of schedules have limited contact with peers and friends. Every time the doctor has this, tomorrow they will get frequent appointments they have to so that their cancer is managed. And of course, this leads to the feeling of isolation and loneliness because um, the medical aspect will take care of them medically, but psychologically, they might live, but imagine what they lose. They lose their friends, they lose their time in which they are going to attend to their businesses, they will lose a lot of time in school, and even people whom they enjoyed, even what they enjoyed in life, they don't get to do it so much. And there's the experience of sense of rejection, being excluded from normal activities because of their health. The things they can't do, they feel they are seen as weak, but in reality, that's what we perceive ourselves, and we ought to have to support cancer patients, and of course, attend of physical appearance or development of disability make them feel embarrassed and refuse to socialize and see friends. Um, the physical change that will happen to them. They might go and feel the shame because of how they look and how they'll be seen by family and friends because of what cancer has done and with the chemotherapy which changes people's physique, and they look at themselves and they wonder, how will I walk to my friend looking like this? And it's also common for relationships within a patient's immediate family to adversely be affected, focus on the sick person, not other family members. So um, within the family, they focus on only one person, the sick person, the person who needs a lot of guidance, but they forget that there's other family members who are asking a lot of questions in their mind. And of course, within the community, is a social group within the community as a social group of people who share common environment with similar goals, beliefs, resources, preferences, and needs. And these communities, the community will affect and identify the individuals within it and understand the roles played within the, as well as the roles the family members is vital accessing psychological needs for the cancer patients, providing support. Family members who are not integrated within the community will likely need a greater input from the team from the team than those who are. So the role of the community is to just create that environment in which this person will be safe, and identifying that person who has a need, and of course giving that support within the community, and provide even that safe environment, given the love, the care, and the support they require on the society level. Patients and family members, for patients and family form a center of community support surrounded by neighbors who are who in turn are surrounded by the broader community, including local charities and faith-based organizations who come together and give that support. And of course, all these are part of the larger social system that bring in the governmental aspect, the lawyers civil structures, their rights need to be protected um, as well, for they're human beings just like you and me. And of course, that if the cancer patient is below the legal age, they need to go to school to learn and grow. They need to go and understand cancer and how they will the support that students. They need to also, once they go to clinics, then they go to hospitals, they need to be respected. Their rights need to be respected. They need to, also they can get the knowledge on how to love and respect and give dignity to cancer patients that they require. And there are people within each of these cycles that gives support and they're able to assist cancer patients and family. So as what aspects should be assessed? Um, they need housing. They need a housing, a place they can stay. They need financing. Palliative care needs financing as well. Give. You need to buy food, the right foods for this patient. You need to be taken care of by this palliative care individuals who are part of parcel. They need to transport to be taken to hospital and back and what have you. During the doctor visits, they need social support services if they need anything that needs to be addressed even from legal level. They can be addressed, referrals were made possible, to ensure that the family's most urgent needs are met. So yeah, their rights also are important and they have to be respected as well. And of course, the role of the family member in palliative care is that family systems, theory suggests that individuals cannot be understood in isolation rather than being a part of a family. And even as a family being an emotional unit, it goes on to say that families are in a systems of interconnected independent individuals, none of whom are fully on their own. Then there are key elements in the family assessment, which include the patient knowledge reaction to the disease. Then there's the belief or bad attitude expectations regarding to the treatment, overcome coping with the ability of previous crisis, and of course history of depression and prescribed drug alcohol use, nature of the stability of residential occupational agreements, quality of relationships, family members, and even the extended ones. And then there's the socioeconomic status of the family, who is aware of the diagnosis and what isn't, as far as cancer patients' family is concerned, and how are you going to address issues within the family level, get to understand the treatment, to get to understand what they can do, to get to understand, to get rid of the pain that they might lose their loved ones, and try and sit out and find out what they can do to at least prolong the life of this life. And of course, before I end, there's the cultural aspect we just looked at. You get to during the briefing of the family, you need to know who is and who is what their previous losses. There's the culture and the belief that families carry, and of course sources of emotional and financial support, during the medical insurance, access of the family unit, knowing the family, and of course it helps with us. And of course, them they'll come with their own beliefs, but they also come with their own beliefs. We are going to we are going to look at the common problems family faces in the next video.